Take it away, John.
All righty, thank you very much. Well, everyone, we're very glad to have you join us this afternoon for this really important discussion about vaccine in the Latino community in the Kansas City region. I want to thank Polo for his debut here. He'll be hosting this first session with us, and we'll be doing so obviously coming forward in the future. We've got two regional experts that are absolutely phenomenal in their work in this arena over the course of the last year, kind of slogging away at this as we all have. But I think their impact on this issue is critical to the success of our efforts in the Kansas City region to really deal with the issues of not only the vaccine distribution and access, but also to basically getting over the hump and getting us on the way to decay for this terrible virus. I'm John Carney. I'm the Center for Practical Bioethics CEO, and I'm welcoming you today. This was supposed to be our final vaccine webinar in our series. We were hoping that in July or August of this year, we would be looking back and saying, what did we learn? And thanking folks for their efforts. Obviously, the virus had a different plan and has really taken advantage of some of our reluctances and our hesitancies and some misinformation and disinformation that has plagued us all. So we're going to continue with this effort. You'll probably have a couple more along the way that we'll be offering to share with you the experts in the field and the ethical dimensions and issues that we face. As I mentioned, Jennifer Sutherlin and Erica Andrade, who Polo will introduce in a minute, have been supreme leaders in helping us address these issues, and I really want to thank them for participating with us today. The center's been at this since the beginning of last year, hosting some of these series around testing and tracing and support, the importance of vaccine, how to address misinformation and disinformation, and particularly focused on the underserved and the marginalized, and that's what we're really going to be focusing on today. We've learned a lot. We've certainly been disappointed. We've got a long, long way to go, as we all know. This virus doesn't care about politics. It doesn't care about ideology. It's looking for hosts. It's looking for transmission, and it's looking for mutation. And we have got to do what we need to do to come together to make sure that everybody here and across the world do their part in making sure that we can eradicate this virus. So with that, I want to thank everyone for joining us, and I want to turn it back over to Polo and ask you all to again, participate as much as you can and to help us along the way. Thank you.
Thank you so much, John. So good afternoon, everyone. My name is Polo Camacho. I'm the Health Ethics Education Promoter and Program Manager here at the Center for Practical Bioethics in Kansas City, Missouri. Welcome to part 4 of the Center's COVID-19 webinar series. Since the start of the pandemic, the Center has released a wide array of ethics content addressing questions related to vaccine safety, the ethics of equitable allocation, and the impact of COVID-19 on marginalized communities. This series is part of the Center's larger effort to not only address, but also highlight and raise pertinent ethical issues that arise within the context of healthcare. This webinar in particular explores vaccine access in the Latino, Latinx community. As with many populations, the Latino community is not a monolithic group. The category encompasses a diverse array of beliefs, preferences, traditions, and needs. Our guest today will speak to this point by addressing obstacles related to vaccine accessibility, as well as strategies for overcoming these obstacles in the Latino community. Joining me today are Erica Andrade and Jennifer Sutherlin. Erica Andrade is Chief Program Officer of Centro, a nonprofit organization in Kansas City, Kansas, dedicated to improving the livelihoods of Latino individuals. She oversees the Promotoras de Salud Program, a volunteer program where community leaders promote health education and outreach within their community. Jennifer Sutherlin has 15 years of experience working as a registered nurse and serving diverse patient populations. She is currently the Emergency Services Health and Medical Program Manager at the Mid-America Regional Council and serves on the Kansas COVID-19 Vaccine Equity Task Force. As program manager, she has worked extensively with hospital systems, local, state, and federal agencies, and public partners in developing responses to COVID-19. Each of our panelists today will be given about 15 minutes to give a presentation, at the end of which we will have a brief discussion and a Q&A, which I will be moderating. So without further ado, I will go ahead and pass it on to Jennifer Sutherlin.
Hi, thank you, Polo. Thank you, John, for the welcome. Good afternoon, everybody. I'm really excited to be here and continue working with the center. They've been great partners throughout this, throughout the pandemic and beyond. And so we are very thankful to have them in our region as partners. So what I want to talk about today is really kind of the data around COVID-19 in the Hispanic and Latino community and what risks they face in particular. Next slide, please, Polo. So the first slide I want to talk about is the trend in COVID-19 cases in the Latino community. And I realize that may be a little hard to see, but the Hispanic population is represented by the green line. It follows along kind of really closely with the yellow. And you can tell that the Hispanic community has been hit pretty hard by this pandemic in particular. And so what we know on this slide is that Hispanic or Latino persons are 1.9 times more likely to have a COVID-19 case, 2.8 times more likely to be hospitalized, and 2.3 times more likely to have death result from COVID-19. And that really important point down in the bottom red box, race and ethnicity are risk markers for other underlying conditions that affect health, including socioeconomic status, access to healthcare, and exposure to the virus related to occupation, such as frontline, essential, and critical infrastructure workers. And we'll get into more of that in just a bit. Next slide, Polo. So we do know that in addition to some of those risk factors that we will get into, persons with comorbidities are at a higher risk of developing more severe COVID-19 and or complications following COVID. And so those at higher risk include, but are not limited to, those with cancer, kidney disease, chronic lung disease, including asthma, diabetes, heart disease, including high blood pressure, obesity, HIV and AIDS, and liver disease. What we know about baseline health statistics is that the Hispanic and Latino population do have higher rates of all of these conditions compared to non-Hispanic whites. And next slide, please. And so all of this kind of combines, and then we start to talk about the social determinants of health. I don't think you can talk about the risk and the increased risk that the Hispanic population faces without considering the social determinants of health. So these are factors that are present in the places where people eat, sleep, play, pray, work, and age that affect health, quality of life, overall risk, and ultimately outcomes. So they include economic stability. So we know that the Hispanic population accounts for about 18.7% of the total US population, but they are overrepresented at 28.1% of the population in poverty. Education quality and access. We know that the Hispanic population has overall lower educational attainment than the general population. It was very interesting. I was looking at this data last night, and while the Hispanic population did have a slightly higher high school completion, very low rates of higher education and degree attainment. Healthcare quality and access. This is obviously a very big one with COVID-19. The growing evidence base shows that patients of different racial and ethnic groups experience quality of care inequitably and disparately. And that was a quote from the United States Department of Health and Human Services. Compared to all other ethnicities, Hispanic individuals had a higher percentage of indicating that they did not have a usual source of care and identified a financial or insurance reason as a barrier. In addition, they were much more likely to indicate that they were not able to get or experienced a delay in receiving medical care due to financial or insurance reasons. Of all ethnicities, Hispanic population had the highest rate of being uninsured in the United States. Neighborhood and built environment. So this is kind of a broad category, but it includes all sorts of things that impact risk. So it's crime levels in the neighborhood, quality, affordable housing, it's air quality, it's access to transportation, it's green spaces where people can have leisure activities and feel safe. All of those factors are affected by income and access to both healthcare and education. Social and community context. This is about strong, positive, supportive relationships and cooperation among agencies and support networks that help build resilience. This also is about increasing health communication and literacy. So health literacy is something that we have talked a lot about throughout this pandemic. And it is the capacity for a person to obtain, process, and understand the basic health information they need to make informed decisions about their health. Lower health literacy is linked to worse outcomes, and people who have a lower socioeconomic class are medically underserved or in a racial or ethnic minority are at risk of lower literacy. Results from one study demonstrated that Hispanic adults have the lowest average health literacy scores of all the racial and ethnic groups. And people with low health literacy and limited English proficiency are twice as likely as individuals without those barriers to report poor health status. Another study found that 74% of Spanish-speaking patients have less than adequate health literacy as compared to 7% of the English-speaking counterparts. So when you take all of that into consideration, and in addition with the biological sort of underlying comorbidities, it's really kind of a recipe for disaster. And so what we really want to know is, where are we with vaccines? So next slide. So this data looks at demographic characteristics of people receiving COVID-19 vaccination in the United States. This is data as of yesterday. And it is a little hard to see, I apologize, but I really like graphs. The top line is Hispanic and Latino. So the red is, initiated doses, and the blue is fully vaccinated. So as you can see, 1, 2, 3, like the fourth one down, the longest line is white non-Hispanic. And so the Hispanic population is lagging quite a bit behind. Next slide. And so looking at our region and kind of our state demographics. So Kansas is there with kind of the little chart. You can see the Hispanic population is lagging behind in Kansas in rate per 100,000 rate per 1,000 who have initiated vaccine. In Missouri, the story is a little different. That's in figure 2. And I was actually quite pleased to see this last night. Hispanic and Latino populations are increasing vaccine initiation and completion as compared to their white counterparts. On figure 3, a share of COVID-19 vaccinations, cases, deaths, and total population as of August 2nd. So you can see Kansas percent of vaccinations, and Missouri is on the bottom. Percent of cases, percent of death, and percentage of population. And so you'll notice again here, the Hispanic population is kind of falling behind. Next slide. So this was quite interesting. This is from the Kaiser Family Foundation. They do a lot of kind of research and data collection, surveying around vaccine hesitancy, vaccine uptake, all sorts of kind of social and equitable health disparities. So in January 2021, the survey indicated that 1 in 4 Hispanic adults said they would get the vaccine ASAP, and 4 in 10 wanted to wait and see. So that 40% is kind of the spot that we want to hit, right? We know that we got the early adopters. They were the ones that said, we're getting the vaccine, we're doing it as soon as it comes out. Likely those individuals have already gotten the vaccine. We have the other population who says, I'm not getting the vaccine. You can't make me. We're likely not going to reach those folks. They've made up their mind. It's really this 40% in January that was the wait and see group that we really want to outreach and talk to and hear their concerns. Next slide. And so among Hispanics, larger shares of younger adults and essential workers expressed vaccine hesitancy. So you can see the total Hispanic adults was about 43% was that wait and see. For the 18 to 49, about 45%. For 50 plus, 39%. And I believe that's where we've seen really a lot higher percentage in all demographics, including Hispanic. The older over 65 really has the best rates of vaccination. Hispanic essential workers really still around that 40% mark that just kind of wanted to wait and see. Next slide. And I found this one interesting as well. This is about trust, and it's not just about trust of the science, it's also about trust of political leaders and the government. So the lighter blue is the Hispanic adults. The darker blue is 18 to 49. So you can see pretty good trust around with their own physician. The problem that we often run into, as we discussed earlier, is not everyone has their own physician. So they don't have kind of that personal connection that they can talk to. They don't have a usual source of care. The CDC, 74% of the age 50 plus, 69% of the younger adults. This has been kind of an ongoing issue that we've seen, not just among the Hispanic population, kind of all over the board. It's been a challenge with a novel virus and the new information, and kind of the situation has changed multiple times. The guidance has changed and it's been based on the science, but that is difficult if you combine it then with the lower health literacy to understand why those changes are being made. Local public health department. This has been a challenge as well. Unfortunately, local public health has been the messenger in many times, and people don't know where to direct their anger and their frustration. So a lot of times it's come out to local public health, especially that local public health getting their guidance from above, shooting it out to the community, and it changes slightly based on the makeup of the community and transmission levels. And so the confusing information can sometimes cause anger and mistrust. The FDA, older adults were much more likely to trust the FDA, 73% versus 62%. So it's a little concerning, and I'm not quite sure what's behind the FDA mistrust. It could again be the differing information, the hesitancy or concern that things were rushed, and not quite understanding the whole background process that had to happen for the COVID vaccinations to come through. Anthony Fauci, I was actually surprised by this one because I call him Saint Fauci in my house. The older Hispanic population, 71% said they trusted him, 58% of 18 to 49. That again, you know, he's a figurehead, he's delivering the information. Sometimes that's just the source of the anger, is the person that you can see. President-elect Joe Biden, this one was a pretty wide range as well, 70% to 53%. There's been a lot of trust and a lot of mistrust, I should say, towards politicians and the government in general. that's especially high in the Hispanic community that we have seen. Some of that is around the need for documentation, concerns about immigration status. We have seen repeatedly that Hispanic and Latino folks are less likely to go to mass vaccination sites and government-run vaccination sites. So there's been much better uptake when those sites are hosted by trusted community partners and state and government officials. I think we've already touched on that. That was pretty low among the younger group. Next slide. So what is vaccine hesitancy? It is the delay in acceptance or refusal of vaccine despite availability. So this was actually a really good definition for me to remind myself on, because as I was considering kind of this webinar and what we've been doing and how we're trying to outreach, I sometimes want to divide it in my head into hesitant and concerned. Really, it all falls under the hesitancy definition. If the vaccine is available and you are delaying its acceptance or refusal, you're hesitant. But it is complex and content specific. So there are a range of things that we need to kind of consider when talking to a hesitant person. Also, it varies across time, place, and vaccine. A person may or may not be hesitant towards the measles vaccine, may be totally different than how they feel about the COVID vaccine. And it is influenced by factors such as complacency, convenience, and confidence. Complacency, I think we've seen a lot of this. Nobody expected us to still be talking about COVID-19 this many months later. And people are tired of it, and people are complacent, and they don't want to wear masks, and they don't want to do those things that we need to do to get out of this. Convenience, we've seen this. In the beginning, those early adopters, we saw they were willing to travel for vaccine. They were willing to go and sit in line and do the mass vaccination sites. People aren't really willing to do that anymore. And confidence, this is a big one. Mistrust in the system, but also mistrust in the science around the vaccine. Next slide. So hesitancy versus barriers. So I discussed this just a little bit, but trust in the system versus the science. So some people just don't trust the science. They feel it was rushed. They feel that they can fare better with a natural COVID infection versus the vaccine. These are things that we're going to have to continue to talk to people individually about their risk associated with the vaccine versus the risk associated with the infection. Safety. We've heard a lot of concerns about allergies. That's that kind of waiting to see group. They want to hear how their friends did. They want to see how their family does. Concerns related to pregnancy. So CDC just came out, I think yesterday, and said pregnant women should get the vaccine. I've seen ongoing concerns about this, even despite that guidance yesterday. Cost is a big one. As we've discussed, Hispanic and Latino population are or have the highest rate of being uninsured. And there are other concerns with cost. So what is the cost if I need to be out of work for a few days? What is the cost of childcare? What is the cost, just the upfront cost of the vaccine? And we know, and we keep trying to push out the information that it is free. But I have also heard that language can be problematic and confusing, because if you do have insurance, they can charge your insurance. So the insurance is The vaccine is provided at no cost to the recipient, but it is not totally free. So the language is problematic and very confusing, and that has led to a lot of kind of hesitancy and mistrust, and why are we charging some people and we're not charging other people? It is free of charge to every recipient. Logistics, talked about missing work hours, the ability to make an appointment, the ability to navigate the healthcare system, having internet access, having language appropriate materials, understanding the culture that people are used to or work within. So that's all the kind of logistics, and the childcare, and can I bring my child if I need a vaccine? What if I do have a reaction and I have a child with me? These are all kind of concerns. The missing work hours, we've seen that a lot in the research, especially with some of these kind of frontline critical workers that maybe don't have time off or maybe work by the hour. And maybe their employer lets them have the time off to get vaccine, but maybe it's unpaid. And that can be really problematic if you need 2 hours off, or if you take 2 hours off and then you're down for a day or two. That can really make a difference. Feeling less informed. So this actually came up in the research. In Kansas was the #1 state where Hispanic individuals reported feeling less informed about the vaccine and its safety and its side effects. And so this is the opportunity we have to really sit down with people and talk to people and understand where they're coming from in a really compassionate, patient way. We know that early in the pandemic, there was targeted mis and disinformation towards the Latino community. And that was essentially active attacks against the health and safety of the Latino community. So we don't even know until we listen to people what they think they know. They may have heard something, they think it's the truth, and maybe it's far from it, but we don't know that unless we listen. Religious beliefs, and we actually talked a little bit about this with some of our faith leaders. There are some faith leaders who are adamantly anti-COVID vaccine. That is something that we've got to try and work through. Other faith leaders are holding vaccine events at their churches. And so really working through kind of the faith leaders and their congregations and their communities is really important. And I actually, I didn't consider this before, but this came up in the research, the altruism factor, that other people need it more than I do. So I'll wait. And while that is, I think, just hugely kind of people, we know that there is more than enough vaccine for everybody. So everybody needs that. And there's really no other people need it more. We all need it. And so all of that data, all of that risk, all of the hesitancy and the barriers leads to how can we do it better? How can we reach who we need to reach? How can we get out the word of mouth that this is safe, this is built with you in mind, we want to keep you safe. So with that, I will turn it over to Erica, who's doing great work, and let her discuss.
Thank you, Jennifer. Well, first, let me, I guess, introduce myself. My name is Erica Andrade, and I'm the Chief Program Officer with El Centro. El Centro is a nonprofit agency. We are celebrating our 45th year anniversary, serving the Latino communities of both Wyandotte and Johnson County. We offer a variety of different services at El Centro, but primarily we work around 4 different strategic areas: early education, community health, economic empowerment, and advocacy and engagement. One of the programs that we offer under our community health initiative is the Promotora de Salud program. Next screen. Thank you. So our Promotoras de Salud, which is, I guess here we would call it a community health worker model, but it is different than community health workers. So for the most part, community health workers are paid employees and they're trained and certified through an organization. Our Promotoras de Salud are volunteer-based. They receive training that we do in-house, but it's not the same kind of model as a community health worker. So for us, our Promotoras de Salud are engaged, then we train them, and then they become active. So when we recruit a promotora into our program, these are individuals that are already natural community leaders. They have strong ties to their community. It could be to their parish, or maybe they just do a lot of advocacy work on their own. For the most part, our promotoras here in-house that we had and that we've had, because we've been doing the Promotora de Salud program for the last, where I think we're starting our 12th year with that program. So we have a long, strong history. I think we've, over the years, me and Ellie, my director of community education and engagement, was telling me that over the years, I think we've trained 160 Promotoras de Salud. So the majority of them are female. They're immigrant advocates, and most of the time their mothers or caregivers will speak kind. So they're very engaged in the communities, they're natural leaders, and so they want to do more. They just naturally want to do more. So we take these individuals and we create cohorts, and then they go through our training program. Our new promotoras are trained in an 8-week kind of training course that we have. It's called Escuela de Promotores, School of Promotores, which was an original concept or original curriculum that we used from the Busco Vasquez Clinic in California in 2008. However, we took that training and adapted it and changed it with the help of promotoras themselves back in 2015 through a grant that we received through the Kansas Leadership Center, which was an amazing experience because they really felt that they created this curriculum to fit them, and not just that, but to fit our region, to fit the Midwest, to fit Kansas and Kansas City. Once our promotoras have been trained, which they get everything from leadership training to public speaking training to conflict resolution or how to have difficult conversations. We do a lot of that kind of work just to kind of get them prepared to what it's like to work with people in the community, and not just the people in their specific neighborhoods. We also do very specific training on different areas. So we do training on Comprando Rico y Sano, which is a healthy eating model. We do work around Medicaid and what it is, and information on who qualifies, because a lot of that's one of the questions we get a lot. We did a specific COVID training that we did through our CDC funded grant that we had in the beginning of the year, where we did a trainer model. So they've also received that COVID training as well. Know your rights. Really, they do a little bit. They have first aid, mental health first aid. They've done that training too. And we keep them engaged throughout their relationship with El Centro. Our average promotora is with us for about 2 years. So in order to be called a promotora and be an El Centro promotora, you have to be able or be available at least 7 hours a week is what they're basically giving to us. So what they do once they become an active promotora is that they serve as a bridge to our community. They connect the community to the resources and the services that we have in-house. Then eventually they themselves provide services. So they're there to inform the community, they're there to educate the community, and then they're also there to advocate. And it keeps us in touch with what's going on in our communities to be able to provide services and programming that is specifically tailored for the community that we serve. Next slide. So specifically for COVID, so I'm going to call this our work about, Promotoras contra el COVID, against COVID. And it's basically the approach that we took back over a year ago when things started happening. Originally, like everybody else, El Centro attempted to close down. I say we attempted because it didn't work out very well. I think we were going to do a 6-week closeout, and we came back in 4 weeks because our staff revolted, our promotoras revolted. They say we can't work, from our houses. Virtual, work was a little too difficult, and they felt the community was really struggling at that time, and we needed to do more. So initially, our first thing that we did is provide relief. And that relief really happened with food insecurity because children were out of school, SNAP benefits, things like that were not lasting as long as they should have. So people were really struggling. So we started doing weekly fresh produce distribution, which we were kind of hoping for it to become kind of like another part of people getting food boxes for dry food goods, like from harvesters and things like that. But our Latino community, we know their diets, we know what they eat. So we know that they still needed to have access to fresh produce that they use in their everyday cooking. So we made sure that that's what we were providing to our families. And then the PEBTs, the pandemic EBT enrollment started coming out for children. And the school district was overwhelmed with the amount of individuals they have in Wyandotte County. That's over 10,000 students. And they just don't have the capacity to help that many individuals, especially when you have technology barriers, language barriers, the same thing that Jennifer was talking about. So they reached out to El Centro and they asked us to help with PEBTs. In last summer, when they opened those enrollments up, in less than, I believe we only had a 4-week window, we did over 900 individual registrations for PEBT. And this was food dollars that came into the hands of families that were really needed it at the time. Then we knew informing the community was super important because there was a lot of misinformation. At the very beginning, nobody really knew what was going on. Remember, we still couldn't get tests at this time. And none of the information was really being created in Spanish. So that's what El Centro started doing. All the content, all the announcements, all the new orders, we were getting them translated and then released into our social media. Then we started working with our promotoras when we got some funding through the CDC to actually create COVID content. We did a Spanish language toolkit, which is available on our website, completely free. Anybody can download it and use it. We have infographics, we have PSAs, we have posters and other materials. All of that was created with our promotoras, and most of them are actually featured in the products themselves. So we knew that that was an important piece of our COVID work as well. And then educating. So this is a little bit more hands-on. This is when you're actually starting to dispel those myths and dispel those misinformations. This is when you're talking to the community and you're starting to talk about, this is when the vaccine started rolling in, the importance of getting vaccinated and why you were scared of getting vaccinated. We started hosting what we call foros digitales, digital forums with Spanish language media, La Mega, Telemundo, Univision, just trying to get faces that weren't necessarily doctors and nurses. It wasn't anybody from the government. It was just your community promotora talking to you about their experience with COVID, what happened when they got COVID and why they were deciding not to get vaccinated. And we thought that was an important kind of perspective to get out there, because those are the kind of people that people will trust, since it looks just like them. It's somebody from their neighborhood. It's a person that they see outside in the information table at the Merck every Wednesday and Saturday, which is what they're doing right now. And then action. So even after we were putting out all this information, we were getting the information out there, we were creating the content, our social media was very active, and we were getting a lot of information out there. We still didn't feel like that was enough. At that point, the UG had already opened up their testing sites, they had their vaccination sites, but we were looking at those numbers. El Centro, we are also part of the Health Equity Task Force, so we have access to the data, and we knew that these numbers were not moving up. So we felt that we have to do more. We're not a clinic, so we don't have medical personnel. We cannot actually inject people with vaccines, but we can partner. So we started reaching out with different clinics or hospital systems or healthcare systems that wanted to partner with us and provide a vaccination site, but at our location. Because and to be real honest, we got some pushback, because they were like, well, they're already available. They're available every day of the week. Yeah, but they're available every day of the week between 9 and 3:30. What happens to the community when they're work double, triple shifts, or when they only have the weekend off? So we knew that they had to be a little bit more available to all. So I believe the first partnership we did was back in early April, and it was with Advent Health. And we hosted we didn't know what was going to happen. We didn't know anybody was trying to show up. And we hosted a vaccine clinic in our Olathe office, which we're talking about less than 500 square feet. It's tiny. It was tiny. And we vaccinated 50 people in like 3 hours. So we knew that we had something. We knew that this is something that we can continue to do and make bigger. And at this time, there was no incentives. There was no, I believe we did get them a grocery bag as they left. We got them some produce as they left, but it was just in and out. And we didn't even have space for waiting. They had to wait in their cars. So the waiting area was their cars. And we're checking up on them. And we were able to do a lot of community engagement that day, where we did a lot of recorded interviews with individuals that had just gotten their vaccine. We asked them, like, why did you vaccinate today? And so that built us another campaign, another social media campaign that we were able to use, where again, they're seeing people that are just like them, speaking their language, who are getting the vaccine, coming out and saying, I feel great. This is wonderful. This is why we should do it. Next slide, Polo. So since then, we've kept going. We've done a lot of events since then, smaller events. Some of them have been a little larger. We kind of created a whole Promotoras in Action kind of campaign with our health navigation team as well, to continue this work. We call it Vaccinate, which is get vaccinated. And so we know that for our community, it's great to have the vaccines available, and it's good to have them at times that are available to them. So like that event that you see in the picture, that was the 24th, which was under heat advisory. It was so hot, but it was in the morning. We were there from 9 to noon. And by 8 o'clock, people were already lining up. And we're like, why are people here so early? It's Saturday. Well, people were trying to catch us before their shift started at work. And so that was kind of convenient for them. But we, had some backpacks, we had some paletas from Tropicana, some, popsicles, things like that. We had some food, trucks available as well, and just a lot of information so that people felt engaged. We're also doing haircuts for children. So we're trying to engage with the whole, like, getting ready for school, getting back to school, things like that. And so it really was a great success, these kind of events. And we knew that these were some of the things that we had to implement. Now, one thing that Polo mentioned when he kind of gave his introduction, he talked about how not all Latinos are the same. We all, we're different. We come from different places. We have different experiences. So even for us in El Centro, which, we've been around for 45 years, all of our personnel that works with clients is from the community, speaks the language. We're Latinos ourselves, the majority of us. And so we are like, yeah, we got this. There are people. We're gonna be able to get this work going. But even we saw how different it was working in different pockets of Latinos. So our original events, yeah, they were great. They were, all we had to do was announce on Facebook, and we were getting calls, we were getting registrations. But then when we started trying to partner with different parishes to do events at the parishes themselves were very welcoming and allowed us to do that. But we did start to feel and see a little pushback from the actual community members, the parishioners. We have struggled, and we are still struggling to really engage with the newly arrived, what I would call like the refugee population, especially coming from Central and South America, has been a really tough group for us to kind of fit in with. We've gotten a lot of pushback. And we had to come back in. We had to have a debrief meeting because we weren't understanding what was happening. We don't understand why we're getting that, not just this pushback, but almost like it was a little aggressive. It was an aggressive pushback, let's put it that way, about not wanting vaccines and not wanting anything to do with us and to even hear our reasoning. And so we had to really look within ourselves and be like, look, we have been used to working with a certain population of Latinos, and that population in Kansas City is changing, and we need to change and adapt to meet their needs, because they're coming with a whole different set of experiences, different sets of trauma, different levels of poverty that we have not, that we're not used to working, and we have never seen ourselves. So those are things that we have to take into account. And so that's when we kind of came out with this bigger idea of having a vaccine event, but that also offers a lot of services that families need, like the free haircuts and again, the grocery giveaways, but then also other information, the PEBT signups, because that's information they're getting from the school and they need help with, so that we're able to really show them that we're not just here because we're trying to get a shot in your arm. We're here because we want to help. We're here because we want to make the whole community healthier and things like that. And also we're trying to see if we can engage and find us a promotora from that community, from that group, so that we can kind of share that we're willing to invest in their groups and their neighborhoods the way that we've done with others as well. Next slide, Polo. So we implemented something at El Centro because even though we were getting people involved, we were having events, we're getting people vaccinated. I think we're like at over 826 individuals at this point that we know that we have registered and gotten vaccinated, which we're super excited about. But I still feel like we can do more. You know, we have different staff, we have different programs. So we're seeing people for other reasons, not just health reasons at El Centro. And I wanted us to take advantage of that kind of contact day to day that our staff have in a way that we're tracking data, but also opening up a way to have a conversation with individuals about vaccinations. So if they're not vaccinated, basically having that second piece of the conversation about why. And if it's something that we can help with, so if it's information, then we can do that. If it's fear, then we can help kind of like ease that fear. But if we don't know what it is, then we can't really tackle it. So just recently, I'm going to say, like, I think we're in week 3 now, but I only have data for 2 weeks that I'm going to present today. We started doing a weekly client vaccine tracker. And so we had a staff meeting, and what I told all my staff, and this is everybody, even the people that are doing emergency assistance, the people that are doing work that's completely not related to the vaccine work that we're doing with the promotoras and the health navigators. Everybody that met with an individual face-to-face, either in person or over the phone, was gonna, they have a little tracker that kind of is a guide to a conversation. They're gonna ask first, are you vaccinated or not? And if they're not, there was gonna be a drop down of the reason why, and they could tell you. And usually we put a drop down because some of the reasons we already knew because we had been hearing them, but then we also left an option for other, and then we could write it down. So we kind of really got the information directly from the people, like what's going on, because then that was gonna help us better design strategies to combat those kind of barriers that we were coming up with. So in 2 weeks, in total, we have asked that question of 220 clients. Are you vaccinated or not? So the first graph, it's a simple one. It's just vaccinated or not vaccinated. As you can see, the majority was vaccinated, but we have quite a bit that were not. We were, what was it, like 92 or something like that were not vaccinated. So then we asked the second question of why not? Why were you not vaccinated? And so there's the replies of the reasons for the non-vaccination. The majority of it, the green, the big part of it, was because they needed more information. So 42 out of everybody that we asked needed more information. Then it moved on to another reason, was another big of the categories. And the most common reply we got for other reason was lack of time. I work 2 jobs. By the time I come out, nothing else is getting, nobody's vaccinating. My only one free day, there's no clinics on Sundays, things like that. Being pregnant was also another one. We had a few individuals that were pregnant. They were worried that they shouldn't get vaccinated when they were pregnant. Transportation was another one of the things mentioned, and then allergy issues. After that, the next reason was fear. We had 15 individuals that said that they were scared. They're scared to get the vaccine. 7 individuals said that they already had COVID. So they were thinking, I already had COVID. I'm not, I can't get it again. Basically, it was misinformation that they had in that piece. And 7 had it. I'm sorry, have it. I mean, they had it at that moment, like, why haven't you vaccinated? Well, I have COVID right now. I'm sorry. And 2 had already had COVID. That's what it was. The great thing that came out of just doing this, out of just 2 weeks that we did this tracker, which is not that long of a time, and we're going to keep doing it from now probably until the end of the year, is that everybody that said that they needed more information or fear, every single one of those 2 categories was signed up for. We were able to talk to them, give them the information that they needed, and we were able to sign up to one of our events, and they got vaccinated already. They've had their first dose. So that's when it hit us that that's really, a lot of it is just that they need to be able to somebody have just a regular conversation with them where they can kind of express their either fear or like questions that they might have without feeling judged or feeling like, oh my God, they're gonna think I'm stupid for thinking this, or I read this and I just can't ask anybody, things like that. And like Jennifer mentioned, a lot of these individuals don't have a primary healthcare doctor. So they go to the doctor when they're sick, but they don't have like a regular person that they have a medical professional that they have a relationship with who they can ask these questions to, or that's going to take their time to kind of like have that conversation. A story that I mentioned to Polo and John when we first had these planning meetings was at that first event that we had with Advent Health. they had a medical professional there just in case there was questions or issues came up. And there was a lady that came in and she was thinking about it. Obviously, she was thinking about it enough to come in, but she was not ready to get it. And I remember that doctor spent 20 minutes talking to her, just talking to her. Every question she had, you know, he had information. And at the end, she got her vaccine. She walked out of there with the vaccine, but he had to speak with her for 20 minutes to answer all of her doubts and concerns prior to that. So that's what that's what we have to be willing to do. We have to be willing to take the time to talk to individuals, to really learn what it is that either they don't understand or don't know about, or what about it is fear. But we can't just assume that because they haven't gotten it until now, it's because they absolutely are no. It's like, I'm not going to get it. As you can see, we did have some of those. We had 11 individuals that were like, nope, don't want it, never going to get it. Nobody can convince me. And they were not going to be moved. But out of the 90 some people that were not vaccinated, that's not a huge number. So that made us feel hopeful that we can kind of move the needle on it. We can continue to talk to individuals, inform them, give them information, but it's going to take a lot of that one-on-one work. Like posters and flyers and commercials are just not going to do it anymore. You're going to have to invest in actually having conversations with individuals to kind of start moving that needle to get more individuals wanting to vaccinate. Next slide. I think that might be it. Yeah, that's just our closer. But so some of the things that Jennifer was talking about that were really resonated with me, because it's exactly what we see, the data shows, but we know it from experience. We know it because that's what we see, is that definitely our community are individuals that some have medical homes, some do not. And if they do have a medical home, it's usually a safety net clinic or a FQHC. They don't have a primary doctor who they have a long-lasting relationship, and a lot of them do have other underlying medical conditions. So those things are all facts. The majority of them are not insured, and they're not insurable. So Medicaid expansion is not going to make a difference to the population that we serve. So we need to do the bigger work to make sure. That's what the Promotoras kind of model is that they want to do the preventative stuff. They want to increase healthy lifestyles, you know, eating better, things like that, staying active and being healthy. And the way they approach it with their community is like, look, you don't have health insurance. You know that if you get sick or something happens, it's going to take a toll on your family because you can't work. It's getting the bills. So you have to keep yourself healthy so you don't get sick. They actually take it that's the model that they use. Whereas our health navigators work with individuals that are already needing health access. They've already either are sick or need access or care coordination to kind of help them get through the system that's complicated, especially for individuals that don't speak English. So that's kind of how we do both sides of the coin on that. And so both of them together are working in the COVID work because it kind of affects all of it. And we know that Latinos are essential workers. We know that the majority of them are not going to get paid time off and do not have PTO hours, things like that. They're needed in the job. And a lot of times their jobs are not going to be okay with them missing work. So these are all true fears that they have. Before they had, you know, getting COVID, but now it's the same thing with a vaccine. If I get sick, just like Jennifer said, I'm going to be out of work for a few days. Who's going to pay the bill? You know, things like that. So just some of the things to keep in consideration as we're working with a Latino community.
Yeah, and so Erica, some of the things that you said, I mean, really resonated with me, and I just love your model and your boots on the ground and what you're doing, and it is your success in getting that number of folks, and it shows in the data. Just this amount of people just needed more information. And if they could just get the one-on-one personal information, they could maybe get to yes. They have questions. I think that's totally normal. I think it's to be expected when you are making a health decision. But if we don't take the time as health professionals or public health professionals to make sure that what we are saying is heard and absorbed, then we're really doing a disservice.
Yeah.
Yeah, and you know, touching on that a little bit, and then after this, you know, we'll field some questions from people. You know, if we think about especially early on in the pandemic, it's sort of like the traditional model for how the vaccine was rolled out. When I got the vaccine, I registered online, got the QR code, drove in this sort of like caravan of cars. We went it felt like we were cattle. I mean, because we're in the car and we literally went through a barn that was designated as a vaccination site. And, we received the vaccine and there really wasn't any space to ask questions. It was sort of like everyone was masked up, show us your QR code, good to go. And we were instructed on how to get the vaccine. Okay, pull up your shirt, get a needle in your arm, go wait over there. There really wasn't an opportunity to ask questions or quell fears. It was sort of assumed that anybody coming through wouldn't have any of that. And so I feel like what's so important about the work that you both are doing is that, you're collecting data about the Latino population and also addressing it, right? And changing that previous model. And so I just, want to commend you both on the work that you're doing. We're really appreciative of that. We will take any questions from the audience right now at the moment. Feel free to drop your question in the chat box, and we will go ahead and ask our panelists here. We have about 4 minutes, so one question I think will be, we might be able to get to one.
I think there was one that came in probably for Erica. So the question was, how do promotoras address the concerns of people who feel they will be reported through the vaccination process?
We have been really lucky that issue has not personally come up to any of our times that we've tried to enroll individuals. One thing that I didn't mention, but I think would be helpful and also maybe related to that question, is that one of the other barriers that we found is that for vaccination, most places when you're trying to vaccinate, you have to either pre-register online using some kind of app, or something like that, or if you get there and you haven't registered, you need to fill out all the paperwork. That is a barrier to a lot of Latinos, especially when we're talking about literacy levels, even if stuff is in Spanish. So first you have the technical issue, which, it's confusing for the apps. Did I do it right? Things like that. Did I know how to register? Do I have a smartphone? Do you have internet connection? So that's the first question. But let's say you can register when you get there. People are just handed sheets of paper, and we've all like most of us have, so we know what it looks like. If writing is an issue for you, you're not going to tell them, I can't read this, I can't write. You're not going to say that. You're just not going to say that. So they're just like, oh, okay, thanks, yeah, I'll come back. And then you're never going to see them again. So for us, when we do events, and even when we partner with events, because we host a lot of events, but we also partner with events, we take over registration. Our clients or people that come in never have to touch a registration form. We do all of that for them. We're just having a conversation with them. They're asking their name and how many people are in their house, because we're also gathering information like, oh, and they're all vaccinated. Who else needs to get vaccinated? They can come and vaccinate if you just call them right now. So we're having those kind of conversations at the same time as we're registering them, just to kind of reduce those barriers as much as we can, so that that's not an issue.
Yeah, and early on in the pandemic, there was really a lag in Spanish translation coming out, and even that access, that language barrier was not addressed for quite some time. So even, if it were me, I would feel really left out of the conversation for a couple months, and then it kind of leads to, well, do you care if I have this information? And so we've really got to get out there and say, your health is important to me. Your health is important to this community. And so I think we just have to keep pushing it and make sure that everything we get out there, we are considering all of the folks on the ground.
Yeah, and in thinking about everything, I think major point here is that when we think about the vaccine rollout, we have to think about it holistically, right? Something that you're saying, Jennifer, and something that you said, Erica, is that we have to start thinking about caring about people's health over, oh, you need the vaccine. You know what I mean? Do they have any needs with respect to their groceries? I mean, can we open up the vaccine clinic early enough so people can get it before work? Can we spend 15, 20, 30 minutes with them to quell their fears and their concerns? It really has to be this sort of like network-minded approach to the vaccination rollout. And I think what points that you all have made sort of are speaking to that point. We've hit 1 o'clock. I just want to thank everyone for joining us today. I want to thank our panelists today for a lively discussion. I think that I can speak for everyone at the center when I say that we're deeply appreciative of your time, effort, and commitment to public health, especially during these very difficult times. Be sure to follow the Center for Practical Bioethics on Facebook, Twitter, and YouTube, and LinkedIn for all the latest updates, content on bioethics related events, educational webinars, and public health resources. As John mentioned, we're going to have a few more COVID webinars, so stay tuned. To all our Ethics Committee Consortium viewers, join us September 9th from 12 to 1 as we host Jamie Watson, Assistant Professor and Clinical Ethics Ethicist in the Department of Humanities and Bioethics at the University of Arkansas Medical Sciences. Jamie will discuss the concept of moral expertise as it applies to clinical ethics, as well as themes from his latest book, Expertise, A Philosophical Introduction. Again, my name is Polo Camacho, and thank you all so very much for joining us. We'll see you next time.
Thank you, guys. Great job.